This is fun, guys. I love the small crowd. I give 5 lectures a month, and usually I do the same one. So when one time I was, what was the name of the place? Holy Family Manor has an independent living. And I went up there to talk, and the guy called me, COVID hit, right? And he said, Doc, there's only 2 people up there. Would you still come? I said, Mike, I talk to myself. Like, that's fine with me.
We love to hear you talk.
Well, what's fun for me is anytime you find something that's problematic, if you don't talk about it, then you're part of the problem. And right now, I have to say it's a tragedy what's going on with healthcare. What I'm seeing every day is wrong. It's not fundamental common sense medicine. And I think we could say that about the world. And my hope is that we at least get back to what I would say accountability. If you're gonna say something, be accountable for what you said. Because I think if we do that in healthcare, we're good. So what's amazing is the way this topic came up is I take care of a inpatient rehab. And it's over at the old Ohio Valley Hospital. Now it's Heritage Valley, Kennedy. You know, you gotta keep up with all the names. And what happens is we get patients there that have head to toe diseases. They could have post-op neurosurgery. They could have problems with their trachs or their thyroid. They can have trouble with open heart where the bone doesn't heal, fractures, strokes, all kinds of things we see. And so what happens is you get called to a point where you have to make a decision on nutrition. And so the topic was mom's not eating. Is a feeding tube extraordinary measures? Okay? And again, what everybody needs to understand is I have a lot of patients that'll tell me, well, you gave me this medicine and had this side effect, or this medicine had this side effect. And then when it's all said and done, I find the patient's taking 5 or 6 things I didn't even know they were taking over the counter. So what it comes down to is you have to communicate. And part of that communication is understanding A, what is extraordinary care, and B, what are the options? It's not like the doctor is saying, I want to put this tube in Mrs. Jones. No one's predetermining anything. So let's call some cases that I see frequently. Probably the most frequent is a stroke. That's called a cerebrovascular accident. And what happens is a condition called dysphagia. And what that means is you have an abnormality of your swallowing function, okay? So if you didn't have it before the stroke definitely had an impact on the swallowing. Does it mean it's gonna get better, not gonna get better? Those things are time. But being in the inpatient rehab as I have for 20 years now, a lot of progress, a lot of things are improving. Okay, keep that in mind as we go through this, all right? Another thing that I see a lot of is infection. And infections, sometimes, not all times, when they weaken you, weaken the patient, you end up with muscular problems. And what is one of the muscular problems? Swallowing problems. Swallowing difficulty. That's what that means by dysphagia, by the way. I'm scribbling because I don't know how to write it. You know how doctors are. Okay, so what you want to make sure you understand is, I see this every day. As I see it, what happens is the patient gets put into a situation of decision making. And the patient is in a weakened state. That's why they're in the inpatient rehab. And in this weakened state, they're making decisions about their future. And that's why I talk about it, because you don't want to make these decisions when all you see is the ceiling and heads popping in front of you. You want to make the decisions now, get the information, know what you want, know what you don't want. Okay, does everybody understand that? Musculoskeletal things I see, MS, Parkinson's, ALS. These are neuromuscular disorders, and they get to come to, not that it's a benefit or an advantage or something you want to do, but because of these musculoskeletal problems, when they're in the hospital, they need to be strengthened to get back into their environment, whatever the previous environment was. Could be independent, could be assistance, it could be a nursing home, but they're in a debilitated state, so we get them in. Okay, so everybody understands. I would say if you think of a stroke, certain infections that weaken you, musculoskeletal problems such as MS, Parkinson's, and ALS, that at least gives you a mindset, plus the neuro cases I see, the post-surgical cases, a lot of times it takes a while for the swallowing to come back. So situations also that come up, open heart complications, if you have an infection in your chest, sometimes that weakens you to a point where the swallowing changes. So what happens? We still have to take care of the nutrition. That's why I was early. If I wouldn't have wrote that all on the board, I'd be writing it now. But I'd rather tell you a joke or something later, okay? So here's your choices. Nutrition, the dietitian calls you up. Dr. Coppola, Mrs. Jones isn't taking in enough nutrition, enough protein, calories. She lost some weight, her protein's low, her albumin's low. What can we do? Okay? That's where the decision making comes in. Now, once again, you didn't plan on being in the hospital. You didn't plan on being in the inpatient rehab. They work you 3 hours a day, so 9 times out of 10 when I come in to see you, I just left, you're sleeping. So you get awakened to the question of, okay, we have to do X, Y, and Z. We're gonna thicken your liquids. You don't have to raise your hand, but I've tasted it. We just had this about a month ago. The girls from OTPT, they brought in, like I walked in and thought, hey, food, because it had all this stuff laying on the table. And here, it was all the different textures. Chopped meat, like everything, and it's amazing. Taste, I have to say, there was taste, but what a change. It's so drastically different from what we're used to, okay? So they'll run through a scenario of, because of the weakness of your muscles of swallowing, we want to thicken all your liquids so that it doesn't go down into the lung, okay? You have to understand this, and I have a good case to tell you about. We'll do the side view. That's an eye. Okay? What we have in here is, we'll put the lungs like this. This is in the chest. And then when you swallow, you have what's called the esophagus. It comes down like this. And then it goes into the stomach. We'll put an S for the stomach. Okay? At the back of the throat, when you initiate the swallowing, there's what's called the uvula, and there's an opening here. This is called the bronchus. So you have this area in here, which is, that might be about the size of it, what I just drew, okay? And when we swallow, the airway is supposed to be protected. But when you get weak, it doesn't happen. And how they check you is called a modified barium swallow. Modified barium swallow. Sometimes referred to as a cookie swallow. And all my patients said they tried to make me fail because they can't imagine that you have to do all these different things. But what occurs is they give you barium so that they can watch and see what happens and make sure everything functions the way it's supposed to. And if it doesn't, then there's a risk that that food's gonna go down into your lung. And if it goes into your lung and causes pneumonia, it can take you out. I've seen 40-year-olds leave the world. Okay, so it's not something that you wanna have happen. So what we end up with is, you're in a situation, given the things I told you from the inpatient rehab, And now they do the modified bury and swallow, and they call me back and say, Dr. Coppola, the patient needs to be on thickened liquids, mechanical soft. And I say, okay. And then the next day I come in and I get yelled at by the patient. Yeah, and now I can answer yes when they say, did you ever taste this blankety blank? Now I can say, yes, I did. But what happens is they're upset. So what occurs? Their life changes. They have a stroke or exacerbation of some disease, infection, what have you. Now they're in a place that they don't know anything other than they're working them 3 hours a day. Someone makes them swallow, they call it paste. They made me swallow the paste and now they won't give me any water. Give me some water. You know, and so you're stuck. And what do? That's the situation we're in, okay? So we go back to mechanical soft, thickened liquids. And they're working you. You have a speech therapist that makes you swallow, tuck your chin in, do all these different things. They're working the muscles. Sometimes they even stimulate the muscles. You have PT working you, using your other muscles, trying to get you stronger. And in that process, you hope there's enough improvement that they can advance this diet, okay? What happens, unfortunately, sometimes is while they're in the rehab, they don't improve and actually worsen. And now you go from a mechanical soft to NG tube, PEG tube, and unless you're seriously ill, we don't do, it's what's called TPN, where they can give you IV nutrition. That's for if you're really, really ill and you're in the hospital just to keep everything going because there's no other way. As long as you have this working, it's all preferred to use this. Okay, so everybody understands that the nutritionist, dietary, whatever you want to call it, says, Dr. Coppola, unfortunately the patient declined. And what happens is when I talk to families, I don't think there's an understanding of what we're talking about. What happens is we get patients, families that'll sign a waiver and say, I don't care, Dad wants to eat no matter what, he doesn't care if he dies. Well, that's nice to say until it happens, you know. So, and I've been there too many times. So I let them sign, just like AMA. You're not supposed to leave against medical advice. But if you're tired of being in the hospital, you may do that. It's the same thing. You do not have to follow what the speech therapist, OT, everybody has said, the modified bear and swallow, but if you don't, and it goes into the lungs, it could take your life. Okay, so what happens, I have a great case. Actually, I'm not supposed to say where the patient was. So I won't yet. Okay? So this patient was, I think he was 86. 86 years old. Pneumonia from aspiration. That's what that's called, what I showed you, aspiration. Requiring hospital 3 to 5 times a year. And I got the finger wag from the son, and I'm only smiling because it happened to be a judge. And so what occurred was, through the conversation, he said, modern medicine, there's got to be something that could be done. And I said, he needs a feeding tube. And you would have thought that I just said something just a change in his face. What, are you crazy? He's 8, you know, and I thought, uh-oh, like you don't want to upset a judge. And so like I kind of tried to calm the situation. And so I got a dinner out of it. He and 3 other judges met me at Rico's. And he says, you're saying it's not extraordinary care? I want you to convince us. That's what he says. And I laughed because I said I got a good meal out of it. And what was interesting about the process was my confidence in the patient. I was telling a story to a patient. I had a 104-year-old, oldest Jehovah Witness in America at the time, that wanted his hernias repaired so he could go to Florida and address the crowd. The oldest Jehovah's Witness in America. And so, I don't know if you guys knew Don Hennon. He was a basketball player for Pitt. We had a son, Bob, right? So I called Bob. I said, hey, Bob, I got this 104-year-old guy, da-da-da-da-da-da. He said, all right, I'll tell my dad we'll do one side. He'll do one side, I'll do the other side. It's okay. So I called Don. And he goes, what? Are you bleepity-bleep crazy? 104? I'm not operating on him. And I said, well, do me a favor. Find somebody to help your son out because he already has a time. So, of course, Don had to do it. And by the way, I got a threatened lawsuit by the 85-year-old son that the father was too old to have the surgery. The reason I bring that up is if you're my patient and I know you, I know whether you're tough, I know whether you're not tough, I know whether you heal or you don't heal, and I know your determination for what you're telling me you want to do. And for me, he checked all the categories. And that case, coupled with the one I'm going to share some more information about, made me realize that it's up to the patient, and ultimately you have to look at quality of life. And you have to talk about that and make sure that you understand what it means, because I hope no one in here has to do this, but if you do, this is a process. Like, these people leave doing fine, even after strokes, because of the technology today. And some do have to get different things done. My father had a ruptured aneurysm. He ended up with a trach and a PEG tube. They call it T&T, trach and tube. That's standard of care. And so, once again, you have to know what's extraordinary and what's not extraordinary. And we'll talk more. I want to finish up with, not finish up, but I want to finish the story because this was wonderful. Like I said, I had a good meal. That's what I thought was the best part. If you guys haven't been to Rico's, it's a good place. All right, so we're sitting at a round table with these judges, and at that time, boy, how long was I doing this? Maybe 15, 16 years, something like that at the time. And these judges had all been doing it at least 30. And they wanted to know, make a case that it's not extraordinary. I said, make a case that is extraordinary. And we went back and forth like that the whole time. But the bottom line was, I said that the person we were talking about, these muscles need to strengthen. And unless you let them strengthen, there's going to be aspiration in his future. And you're saying that we could do a PEG tube and he'll get that all stronger. I said, that's your only choice. That's the choice that you have. And so, amazingly, it was 5 years where he stayed where he was, and then he had to move from there because he started to get some memory troubles. But in that 5 years, talked, interacted, did everything, went to family functions, etc. It's not what everybody thinks it is, and that was the purpose of today because I'm seeing it so frequent now. I've probably been doing this about 20 years, but in the last 5, we get sicker patients. They get out of the hospital faster now because they don't stay as long as they used to. And you get into this situation where you have to make these decisions, and this is one you want to understand what it provides in that decision tree you want to recognize. So here's what I want to make sure everybody thinks about, and please do not check off that you want a feeding tube because of this conversation. When we're done, you're going to understand the physiology and what happens, and ultimately your chances of improving, and if you do improve, are you going to be able to get back to water? That's what a lot of patients ask me. They want to get back. Oh, I'll give anything for a glass of water. And I have fun doing it. Like, I shouldn't say fun. I have 2 people there right now, a 97-year-old, which is cool as ever, and an 88-year-old, both of which had the Dombrov tube. That's the one that it clicks up here so you can't pull it off, and they hated it, and they wanted it out. And from day one, they wanted me to pull it out. And all I kept saying is, one day at a time, one day at a time, one day at a time. They both passed their MBS. They're both progressing up the ladder right now. And I don't know them. Like, that's why I'm talking about it, because the patients I know, like I told you, I know if they're strong enough to get through, if they're going to get through it successfully, people I don't know, I still have to give them the information. And please, whoever your power of attorney is, make sure they understand what you want. Because what I find is I'll have a conversation with the patient, and then I'll walk out and the nurse will call me and say, Dr. Coppola, this daughter's in seeing the lady in bed 5. So I go back and the daughter's saying, no, don't let him put a tube in you. You know, that's surgery. And so that's why I wanted to make sure that we talk about this part of it, the decision tree, and now understanding it and recognizing the discussion. What's extraordinary care? Oop, there's an R in there. Extraordinary. What's ordinary? Am I spelling that right? Doesn't look right. I'm a scribbler. Ordinary. Okay? I've been doing this for 34 years, and I was blessed to have physicians in the family. So I've been in the hospitals since the early 70s. And I watched my uncle take out my brother's appendix when he was at Little St. John's Hospital in the ward. Meaning, like, you don't need operating rooms, but you do need operating rooms. Why? To prevent infection. But again, I was probably 14. I think I was cutting grass that summer. And all of a sudden they called a code. And they felt that it had ruptured and it would be sepsis. And he was young. So right there, they brought the whole OR team in. They put drapes around as best they could. They tried to get in there with the sterile sheets and everything else and had emergency surgery done. And it made me realize so many things about changes that occur over time. My uncle, he was an intern at St. John's, and we always were taught that the urine of a diabetic actually has a sugary smell. These guys as interns had to taste it to confirm it. And you hear that and you think, oh my goodness, how could they do that? Well, there weren't the rules that we have today back then. And so what happens is you go back to, I spent a lot of time talking to him, seeing the procedures he did, all the things that went on. His son did the same thing for years. So I saw that in my lifetime. And then I've seen what I've seen in my own practice, and what I recognize is you have to understand what is being discussed, and you have to have the information. Then you make an informed decision, and whatever decision you make is right. I'm telling you, do not walk out of here saying, oh, if I ever have a problem, I'm getting a feeding tube. I'm not trying to sell feeding tubes. I'm just using it as the example. You know, mom's not eating, do we put in a feeding tube? Okay, so keep that in mind. All right, so what we want to do is look at, let's go ordinary care. Comes in 3 flavors. Chocolate, vanilla, strawberry, right? All right, the first one is common sense. Is this March Madness game today? That's probably my bookie. Okay, common sense, pressured, and experimental. Okay? So, ordinary care would be, you cut your finger, you go to the doctor, and the doctor puts stitches in. And if you did this, say, 60 years ago, you didn't get Novocaine. You know, they would just put it in like that. Now, they glue it. You follow what I'm saying? So what's ordinary care? I remember the staples. They went from suturing to staples. Why? Less infection with the staples, easy to take out. And then they went to gluing. Why? Less problematic situations with the patients. They don't have to come back. It's glued, it's shut, no follow-up. You know, Is it as good? The data showed that it was as good. But my point is, everything changes over time. So what was ordinary, imagine, when was I with my cousin? Probably in the early 70s. And imagine if in the early 70s you told somebody that, yeah, we're gonna clean it up and then we're gonna glue that. You know, they would think you're crazy. They think that's extraordinary care. Like, what are you doing? That's how you wanna look at this. It's not so much that what is being described is so much removed from quote unquote mainstream. What it is usually some new technique or technology. When I first started, I wanted to be a surgeon. And if you had to do what was called a colon resection, that you had to take out the bad part and then you had to put like 66 sutures around each side in order to reattach it. And sometimes you did a colostomy and then reattached it later. I was at Hammett Medical Center in 1978. I forget the company, but it looked like a pair of scissors. You went like this, it cut the bad part and put staples in the good part. Just like that, boom. So when that was first coming out, it was called extraordinary. Why? No data. All they had were animals. But once they saw, A, it was clean, B, it was quicker, and the patients improved. So it goes from extraordinary when it first comes out to ordinary care. And those are the common sense ones I'm giving you, okay? What happens with the pressure, that's when you're in a situation, I wasn't the main surgeon, but I was in the situations where you go in and you tell the family that, okay, we're gonna try to do a scope, but we may have to open you up, okay? And you sign on that form, and when you sign it, no one's intentionally doing anything different, but when they get in there, they see something, they're in a pressured situation, and they do what they need to do. That's where a lot of these techniques come up. That's where a lot of the, what used to be common sense changes, like the PEG tube is a good example. If anybody's had an endoscopy, they place a tube down into your stomach. Your stomach's right there. I've done them. When you shine the light, you keep it in the lumen. But it can move any way it wants. If you shine it up, you literally, just like my button, you see a light literally right at the stomach. It's there. So the endoscope is right there. With the scope, they have forceps. So on the other side, everybody's had a tooth pulled with Novocaine, right? Little shot of Novocaine, you don't feel a thing, nothing. And the doctor makes a little nick. Tube's in. That's what it is. It's not major surgery. But over the years, it was always thought to be extraordinary. Once you get to the point where you see the technology and you recognize how it benefits. How's it benefit? Okay? We'll go to experimental in a minute. Let's go back to this one when you're in a pressured situation, because I think a lot of these changes that occurred over time is how that occurred. All right, so let's do it. We'll do the side view again. Esophagus, stomach, belly button. Okay? So what happens is they pass the scope through, comes down to the stomach, they shine the light. On the other side, you inject some Novocaine, you pass the tube through the opening now, they grab it with the forceps. And what they're able to do is secure it with what they call it a button, where on each side there's about that big a round of material that doesn't irritate the skin, but keeps it in place. So the procedure is simple. What can it do? Answer? Oh, there you go. Everything. What's that mean? Medications, nutrition, fluid, I'm missing one. I'll figure out what the next one is. But the main one is the medication and the fluids. Obviously, you got to get fed. So what happens? They have to put you up in a 40 to 50 degree position at bedtime, and they run the food. And then first thing in the morning, they flush it out, and you get your medicines through there. And then they keep it open air through the day. But if you're dry on the lab work, they put the fluid in there, you know, and you don't feel anything. There's no pain. There's no problems, you know. Anything can have complications. So I'm not saying it's perfect, but I'm just suggesting that you understand the simplicity of the test and the fact that I would say, let's see, my father passed in 15. So what is that? 8 years ago? 9 years ago. So for 9 years, it's been standard of care. You'll hear him in the emergency room, you know, call the doctor and say, such and so, so-and-so, we're sending so-and-so up. You'll hear the operating room clear it, the anesthesiologist comes down, and they call it T&T, trach and tube. Trach's a whole different story. You know, that's something that is more invasive, definitely has things that could be socially stressful. But the PEG tube, it clears up, it looks like a little, like you had a scratch. You know, it heals. And so what you want to make sure is you have an understanding of it. And once again, the medication, the nutrition, and the fluids, if you're in the CCU, the ICU, if you're in one of those facilities and you're getting acute care, you already have IVs in, you already have the Foley in, you have to have the ability to take in the medicines you need. You can give it intravenous, don't get me wrong. But if it works, why not use it? That's the concept. And again, that's how it came to be, was what was being done for the nutrition end. They had to do the hyper-al. There were so many complications. This was the easiest way, very simple to get done. All right, so everybody understands that concept. All right, now let's get back to the experimental. I had a great case. I had a patient that was at a family reunion, and she was dancing with somebody, and they stepped off the dance floor. And when they fell, she broke a couple vertebrae. And when she went to the hospital, they found a pancreatic mass. But it was caught early. That's how lucky she was. Had she not fallen, she wouldn't have had a test done. She was my patient. She had no symptoms. And there was a doctor in Pittsburgh at the University of Pittsburgh, Presby, and he was doing experimental treatments for pancreatic cancer, okay? And he tells you flat out, this is an experiment, all right? You have to understand what's involved with pancreatic cancer even today, but how it's all moved forward. Okay, we have to draw this view this time. Okay, esophagus, stomach. We'll draw the stomach like this. And behind the stomach, literally behind the stomach, I'm going to put dots around it because it doesn't have a covering, is the pancreas. There's a tail and a head. Off of the stomach, C loop is called the duodenum. I'll put a D up here for duodenum. Okay, then you have small intestine and large intestine. What we had to do back before the scope and some of the techniques that came up, it was called a Whipple, W-H-I-P-P-L-E, a Whipple procedure. Very, 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 very difficult surgery. You remove the circle, you remove pretty much everything that's in there. And you end up removing the cancer out of the body, and by doing that, give the patient longevity. That's where the surgery started from. This guy came in, and we'll show the pancreas like this. He did what they call a wedge resection. This is the cancer. He would go in and take that out. And he had tremendous results. Changed everything when it came to pancreatic cancer. And it was remarkable because it was my patient. She came back to Pittsburgh because she felt it was better. Came back to Pittsburgh to get the surgery. I'll bet he's done 25 of my patients over the years. Unfortunately, they snatched him away. He's in Boston now. And I don't know the people down at Presby of who's doing it, but they do it. The point is, it was experimental. What does that mean? That means if someone tells you, okay, Mrs. Jones, you have this cancer in your pancreas because of where it's located and what it does, and I told you guys before, what does it do? Anything that passes your lips, it has a response. Water, it puts out buffering, bicarb. Sodium, it puts out potassium. Sugar, it balances the sugar. Protein, it puts out enzymes to break up the protein. So the pancreas functions constantly. So what can you do? Well, if you remove it, you just have to give the body what you're now removing from the body. So you have to take the enzymes, the lipases, the different things to break down the food. You have to take your insulin, all those things. So years ago, and I was working in the operating room with my uncles when they did the cases. Like devastating surgery. Very, very difficult uphill, kind of rehabilitation, if you will. And then survivors did pretty well. They always based it on the 5-year survival. If you got the 5, you did okay. I've had patients have the surgery done and they're back. They have to go to a facility, but they're in that facility within 72 hours. And it's pretty phenomenal. And how it worked out was this guy started doing the laparoscopic procedures, and what he found was he was testing the organs in animals. And the pancreas works very, very hard. It doesn't have any kind of layering over the top of it, so it doesn't have a capsule over it. And that's the bad part and the good part. The bad part is if it's diseased and it starts to put out enzymes, it'll eat itself. That's the bad part. The good part is that it's free, and that freedom enables it to maneuver based on what you eat or drink. So you have a situation where he's talking to the patient, and the patient wants to know, what's the risk? A lot less than the Whipple procedure. What has your outcomes been? And again, what they do is they remove it, look at the tissue, and then the oncologist, based on what the tissue looks like, puts a plan together. A lot of them don't need chemo, a lot of them don't even need radiation. But that's all up to the oncologist. The point is, this was experimental. Everybody understands that? It just came to be. Another one that I talk about from the experimental side of it, and one that you want to make sure you pay attention to, lung cancer. It's called small cell. That's what the cell looks like, okay? And what happened is they experimentally used a type of chemotherapy on patients that were end stage and they really didn't have anything else to give them. And that's where experimental comes from, that you know what this particular medication does in the lab, but you have no experience with the patient. And so you find that patient that says, hey, doc, what do I have to lose? Give it a try. And it turns out it's a pill, and it's amazing what occurs. So again, you have the process is one that I like to list as I did, that there is 3 things, 3 flavors. Common sense is common sense. When you get pressured into things and you do what you have to do, the experimental one is the one that I think guides medicine, especially in America, because you have engineers thinking things through, you have specialized people that get involved. And for those of you guys that don't know it, the treatment for lymphoma is radiation, and it was a person in Pittsburgh, Pennsylvania that ended up with the lymphoma and came up with the concept of being able to not damage the tissue as the beam went in to get to the cancer. And that's the technology that comes from the devastation of disease, and ultimately whether it's the provider that's caring for you or the patient that comes up with a concept. I had a patient, his wife had one of my first cases of Lyme's disease that affected her mind, and it's called a cerebritis. And we got her to a specialist. She did pretty well, but she ended up with a neuropathy where her nerves hurt her all the time. So she came in, and I asked her what was wrong because she had these welts on her arm. Her husband became a beekeeper because he read that the sting, whatever was in the sting, the protein in the sting, would stop the itching and would stop the sense of just being tight all the time. So he would sting her with these. And it turns out the whatever's in it, that ingredients, it's over the counter and it's one of those non-medical things, but it has some benefit to it. And then what was really nice is he's still a patient. He came in, he goes, "Doc, you're the one that told me that honey cures everything in the wintertime." I said, "Yeah, that's what my father and grandmother used to always say." And he said, "You told me not to buy nationwide, you wanted to buy local." I said, "Yeah." Well, Holly had passed away, that was his wife. So he had Holly's honey, and he was selling Holly's honey. And I thought it was cool, guys, just the fact he thought outside of the box. All right, now what I want to make sure everybody understands as we go through the whole whys and wherefores, why I got involved with it is the number of people uninformed. I'm not suggesting a trach or a tube, but I'm telling you with the trach, the airway divides to it gets as small as the tip of a pen. And sometimes the disease in the airway causes a problem, so they have to put in what's called an endotracheal tube to ventilate you, meaning you can't ventilate on your own, so they have to put it down. Sometimes they can keep it a length of time if they think that your illness is going to come together, say in 5-7 days. But if they're seeing projected longer than that, they'll talk about a trach, okay? Which goes at the cartilage in the neck. It enables you to have the airway cleared out with suction, which sounds horrific, but believe me, to a person that has that disease, that mucus is so hard to get out. And so all the coughing dilates the blood vessels, dilates the bronchi, it makes it more difficult. And so this, again, is one of those things that when you put the trach in, it gives you access to the lung. And the lung has the largest capacity surface for medications. So you can give medications in that way. You can definitely ventilate the patient that way. And then you have to wean them off of it. So I don't necessarily say that the trach is common, ordinary, but it's disease. That's what you have to look at. If you're going in and you're very sick and your lungs are a problem, whether it's building up with fluid from heart disease or mucus from lung disease or problems related to whether it's ALS where you can't take a deep breath, the trach is a good way to go. Once again, how does it happen? You guys have all watched MASH. Do you remember when they had to do it with MASH? You feel the hyoid bone, which feels different than all the other ones, and there's a space there. And that's where they place the tube. And once they pull it out, it heals up. You know, my father wore turtlenecks for probably, I'll bet it went 6 months. He wore these turtlenecks. And everybody was like, "What do you wear those for?" And he says, "Look." And he pulled it down. And all of a sudden, we all went like this. And he goes, "What are you doing? We can't see it." So he runs in the mirror and looks, and he goes, "Hey, that's not bad." So he quit wearing the turtleneck. Everything heals up. It just takes time. And once again, it's safe. I think the key to extraordinary care is if you question that care and you worry about safety, then I would say it's not ordinary for you. But trust your physician, talk to your PCP, make sure you have to understand, guys. That's why I talk about the uninformed. What occurs now in healthcare, time. There's only so many hours in a day, and I don't know. I'm gonna guesstimate 15 minutes a patient is what I'll say. All right. So if you're able in 15 minutes to explain to the patient everything they're going to go through in the procedure, then I think that you have plenty of time. But if they're not informed on the front end, you don't have the time. And you know the good ones from the bad ones in terms of communication. I'm not talking about surgical skills. Like I'll have patients that will be having cataracts. And I'll say, okay, what did the doctor tell you? Nothing. Did anybody tell you about what you have to do? Oh yeah, the nurse gave me a sheet. Did you read the sheet? No. And if those of you guys have had cataracts, you gotta get drops. I mean, there's things you have to do after the surgery. Why didn't the patient know? Because they were uninformed. Handing a sheet to a patient, it's funny, I tell people in my world, my environment, if you will, don't give me anything, don't put anything in my car to give to somebody. Why not? Because it'll still be sitting there next year. Like I don't do that well, so I tell people, don't do it. Well, if you're not informing the patient that's having a procedure out of your office what's going on, you're falling short of standard of care. To me, if you're removing a cataract from the eye, you better explain the whole process. And it doesn't nowadays with extenders, it doesn't have to be the doctor. If those of you guys that knew Joanne, she used to always say that she knows it better than me because she's been doing it longer than me. And I sometimes agree. But the bottom line still comes back to you want to have the information about what's going on. And again, guys, for me, it's not a matter of spending the time, it's a matter of understanding. So what do you need to understand? So the question is, what procedure are you having? What are the complications? And how long is the recovery? Minimum. Those questions should be answered so you do not have to ask. You follow me? So whatever you're having, pick the cataract again. What's the procedure? Cataract. They shouldn't just say cataract. They should have something to show you what exactly the doctor's going to do. What are the complications? They should list verbally to you what the complications. How long for recovery? That's important as you make a decision. I mean, I had a patient yesterday, remarkable, 35 years OBGYN nurse, and she came in, both her shoulders, rotator cuff tears. And long story short, every time she was told by the surgeon, like, okay, do this, and we'll do this, something would happen to her, okay? And so she's at that point, so she doesn't want to do anything with her shoulders. She can't lift further than this with the right, and she's right-handed, and the left she can't go out with it, and it's all from the shoulders. And what happens is, each and every month that goes by, she's doing less and less. And so you run into a situation where sometimes the surgery is good for the future of the patient. Do you convince them and twist the arm? No, you just lay it out. Well, they said that it couldn't be done. Yes, it can. Just like they do 2 hips, they'll do 2 shoulders. What's tough about it? The recuperation. It is horrific time. It just takes a lot of time. But it can be done. So all those things you need to have answered. The last thing I leave you with when it comes to extraordinary care, I'll just put extra. What you want to make sure you do before any illness hits you is think through the changes that can occur and make certain you keep an open mind. All the places I go to, we go to a lot of places. We still go to Passivant, AGH, Swickley, all these different places. You see so many of the same things now. There's no hands-on patient care. Everything's on the computer and everybody's in a hurry. Okay, so what you want to make sure of is they call them a navigator now, if you haven't heard that term. What physicians are using are navigators. These are non-professional employees, meaning they're not nurses or extenders that way, but they're people that come in to navigate you through the process. Because what happens is, say the surgeon's gonna take a total knee, and they tell you everything you're supposed to do. Well, if they miss on the parking site, then you have a terrible time because you're late from having to try to park and all these things. So trying to go through that checklist, they call them a navigator. Started with ophthalmologists, then it went into oncologists, and now a lot of internists are using the same thing. And that helps them be able to be sure you're getting all the information that you need, and they take you through the procedure. So if you're gonna have, say you are gonna have your knee done, they will be there in the morning when you go back to get the surgery done. They will be there when the surgery's over, and they will coordinate the care after you have the procedure done. So what I see with that is they changed the healthcare system so much, they're sending them out so early that you have to have a navigator now. But I still recommend it for anything you need communication-wise. They're excellent, and they're no charge from what I understand. Yeah, but right now they're only just moving a little bit into internal medicine, real big with ophthalmology and real big with oncology. Because let's say oncology, you need to get chemo, radiation, you need to follow up. They guide you through that whole process. Okay, so again, guys, the extras, I don't think that today's day and age, anything is really extra or extraordinary. I think it's all communication. And again, the experimental, know who's doing it, who's doing the experiment, so who's doing the research. And I have to tell you, I leave you with this whole scenario. Anybody ever heard of med beds? Well, I like telling you guys stuff for the first time. Okay. Crystals out of Africa. It send off photons, okay? Electrons, protons, photons are in our body. And what happens is, the studies have shown that these photons give you energy through your cells. It helps the cytoplasm, like the energy producers, the reticular activating system, the ribosomes. It actually helps them. I refused to do anything with it until I saw it work. Well, I have 5 people that it worked on, one of which is my wife. And if you can convince my wife, you can convince anybody. But Dr. Jagiello was the first. He called me, he was gonna get surgery, he tore his labrum. And then he called me to say he was gonna try the med beds first. And then he called me back, said, I don't need anybody covering, this is working. And it's pretty remarkable. What's coming out is a whole different concept to the body, healing, disease, and it all has to do with frequencies and wavelengths, and how those frequencies and wavelengths get our attention. Sound. I mean, it's pretty remarkable, guys. It's, I think I told you also that it's called NuCalm, N-U-C-A-L-M. And I did it before I told anybody to do it. The girl that was doing it used to do all my lectures with me. Her name's Kathy. And Kathy said, all right, how long do you want? And I said, give me a half hour, because I was still had to do some work. So you put on these dark glass, like you can't see. When you put them on, it's black. And you lay down in an overstuffed chair, and you put these pods, or whatever they call these ear pods in, and they start it. And these sounds, it's not music, it's sounds. And I remember thinking like, oh, and my phone was right here. Hour and 15 minutes went by, and I didn't even know it. She said, I don't set the alarm for people that are trying it for the first time. She just wanted to see it, and you feel It's a calming effect, invented by dentists for their patients. And now every sports team in America is using frequency to the ear, which is by the temporal lobe. And I haven't done it yet, but the way this is set up, it's in Butler. They have a workout place, probably twice the size of this, and they have all these apparatuses that emit the photons in that. And now what they're looking at doing is pickleball. Anybody heard of pickleball? That's like a craze now. Everybody's doing pickleball. So they're thinking of doing the pickleball in this stuff as well. So for me, what I bring it up for is recognizing change is still coming. So what's going to be extraordinary? You know, if things like this that they're talking about are true, I think you're going to see a whole different type of delivery system of care that could benefit you. Okay? Any questions, guys? Yes.
I have one question. Or if anyone has a question, wait for the microphone so they can be on the video. Okay.
Oh, okay.
But I do have a
You guys
question.
want to get on TV?
Yeah, but I do have a question. You know that what prevents? Isn't there a valve that prevents the food you eat to go into your lungs? Like instead of going into the bronchus or past the uveal, isn't there a valve there that?
There is.
What's it called? Do you know?
Molecular.
What's it called?
With a V. Molecular.
Oh, molecular. Is there
Yeah.
any way to strengthen that so that?
That's the whole process they do. It's called e-stim, where they actually do an electrical stim to it, depending upon how weak it is.
Mhm.
But that's speech therapy. That's their expertise.
Oh,
And they'll
okay.
have you phonate, because passing air past
okay.
it helps strengthen it. So they'll have you do different enunciations like you're in first grade again. And they make you, like they sit there and make you do it for an hour and a half. That strengthens those muscles.
Can we do anything like now?
Sure.
I mean, like just turn your head and swallow, or I mean,
Chin
without
tucks, chin tucks. It's a good point. And what I'll do is, let me see if I can get one of the girls maybe even to talk to us up here.
yeah. So
Like
we
I
can
can invite them up.
strengthen
so
muscles now, maybe.
Sure.
You know.
Definitely. It's a good idea.
What's it called? Skin tuck. You know.
Molecular.
Molecular. Okay.
V.
Molecular.
Molecular. Yeah.
Okay.
And what happens on that gets weak. What happens when you have
Yeah.
one of these illnesses, when that gets weak, you have to hope it strengthens back up to protect the airway.
Okay.
And until it does, that's why they thicken up the food.
Very good. Thanks.
Sure. Any other questions?
Oh.
Just making sure it's still working. Thanks, guys.
All right.
Thank you.
You're welcome.
Thank you.
You guys do the same.